Yes,
Hello?
sir. It's connected and it's very clear, sir.
Satish sir.
Yes, Satish.
Hello?
Yes.
Yes, sir.
Yes, Satish, I'm here.
Sir. So yesterday we discussed a lot about the radiology. Like we always discuss, our protocol is to get a fine section axial cuts done. See, this is 0.6 mm, and then we extrapolate in different, images through our DICOM. And this is how we can get the axial, coronal, and sagittal sections done. If we want, we can get oblique, so many transverse, longitudinal, oblique, so many things. For more details, nowadays we are trying to get more and more information regarding certain cells like onody and frontal cells to get more three-dimensional view. So we'll come out soon with that. But right now, what we have are axial, coronal, and sagittal sections. Like discussed yesterday, we had three different situations. And today, this first case is so exciting to share with you. Let me first share the coronal images. And see, the CT, the dynamic CT is the only thing which can tell us exactly what it is. Printouts can never. See now, the first image anteriorly. Satish sir, feel free to interrupt me anytime. Your suggestions, your every single word coming from you is important for us.
No, Satish, please carry on. I'm listening.
Sir, so this is the first image, coronal. See this 0.3 mm section. Amazing. Every single move will go by 0.3 mm further. You can't miss any damn thing in sinuses with 0.3 mm sections. I know all these sections, in the individual setting costs a lot because prices for CT scan are calculated by means of slices. So I know it means, but it is so important. See this, I will show you the importance of these fine sections today in this particular case. Otherwise, one can easily miss what exactly is going on. See this, the first picture, what we see here, the frontal sinus on the left side, frontal sinus looks like on the opposite side, looks like some intersinus septal cell. See now, as we go, it communicates. Can you see this? It communicates with the sinus on the left side. See, all these scallopings, they communicate with the sinus. So all this part of the left sinus, this looks like intersinus septum. As we go behind, now see the most interesting finding in this case. As we go behind, still my sinus is intact, the floor is intact. See the right sinus. The drainage of the right sinus and the overall right sinus is narrowed. As you go behind, I'm going behind. Every time I'm going behind. See this intersinus septal cell over here, communicating to the right sinus. See, so interesting. Earlier, this intersinus septal cell, 2 anterior was communicated to the left, and this one, as you go behind, communicating to the right. It is so clear. This one, the posterior one, intersinus septal cell, is communicated to the right. And see another pneumatization coming and narrowing the right sinus. See, if I go back, this is the right sinus. And see another pneumatization narrowing the right sinus drainage. See this is the sinus. And see this pneumatization coming. See, this is completely narrowing the right sinus drainage. And what it is this? See this? This is supraorbital recess. This is supraorbital recess. If I go back anteriorly, see this, imagine this is supraorbital recess. And see, this is the frontal sinus. And this supraorbital recess has narrowed the right frontal sinus, outflow. This right frontal sinus is sandwiched between this intersinus septal cell on one side and the supraorbital pneumatization on the other side. And see, this right sinus drainage is compromised. And see, this compromise is because of this see this, if I go posteriorly, this is the level of the cribriform plate. This is the supraorbital cell. This is the supraorbital. This is on the opposite side. This is on this side. But see the difference on both sides. The opposite side is not very big. See this? That's the frontal sinus on the opposite side. But here the frontal is narrowed. Frontal is narrowed and the supraorbital limitization is much bigger and narrowed the frontal drainage from laterally. This this intersinus septal cell narrowed the frontal drainage from medially, and this frontal sinus is sandwiched between these two cells to drain from here. See, the frontal is draining from here, and that's a narrow drainage, and that is probably one of the predisposition factor, anatomical factor for sinusitis when other, pathophysiology is going on. So that is one of the most important, remarkable finding in this particular patient. We were expecting variety of frontal sinus situation, and this is one of them. Now, another thing. Yesterday we saw a huge type 3 narrowing the left side of the frontal sinus outflow. We went behind and up the type 3 cell and got that cell fractured to widen the frontal sinus. On this side, there is a small, I would say, cell above the level of the beak. So these are the cells below the level of the beak. See this? If I go far anteriorly from here, there is Agarnese cell. Some more cells at the level of the beak, but this one is above the level of the beak, and we have to be careful. See this? This is narrowing the outflow. Once I remove this cell, the frontal outflow will be much bigger. So on the right side is a different scenario, where you see the supraorbital limitization has superseded the frontal sinus opening and completely, change the situation. One can easily be mistaken with this cell as a frontal sinus. This is a left, this is a right frontal sinus, which is actually not the frontal sinus. That is a supraorbital limitization. And frontal sinus is here, sandwiched between the intersinus septal cell and the supraorbital cell. So interesting. Now, if we see below, so far as far as the beak is there, we don't see the maxillary sinus. Now, as you go behind, yes, sir. That's the maxillary sinus, and what is this? Is the supraorbital limitization, and what we see in this case is the high deviation of the nasal septum as well on the left side. On the left side, we may have to do some limited septoplasty, not only for the axis, but for the post-operative. You have to ensure that your irrigation should reach freely, uninhibited, uninterrupted to all the sinuses which we have opened. So that is one of the factor which is important to consider. What happens sometimes, you have a deviation, and when you decongest, you feel like you can go ahead and carry out your sinus surgery procedure without any issues. But yes, you can do that to the narrow space, whatever you want to after the decongestion, but it affects later on once it's come through irrigation post-operatively. Because if your irrigation doesn't reach effectively to the sinuses, is one of the major factor determining the outcome. So in sinus surgery, again, for those who have joined today, we have multiple goals to achieve. It is not simply that we do sinus surgery and patient is going to be cured. The sinus surgery will open up all sinuses, will establish the ventilation and drainage. Number one, it will remove the inflammatory load, maximum inflammatory load, which is not being tackled by the conservative management, whatever polyps, fungus, pus, whatever, which is not tackled by the maximal medical management or adequate medical management. And third one is to give access to the topical treatment, which is the mainstay of treatment, wherein you can push high doses of topical steroids, whatever, in case antibiotics required, whatever, yet without systemic side effects, even for long run. Because this disease, this polyposis, is most of the time eosinophilic, and the cascade of this entire pathophysiology, at every level of the cascade, if you look, it is the steroid which works. So this is basically a immune compromised situation. This is immune mediated mechanism which leads to sinusitis. It is not, as the name implies, that it is an infection. It is never an infection. Infection can be a contributory or a comorbidity later on, but never an inciting factor. But it can be a comorbidity, but mostly it is a inflammatory disorder. And yesterday somebody asked, the patient is induced. We have 5-10 minutes, and I can share some of the things which I was mentioning, what kind of disease it is. So this is basically inflammatory disorders, and sinusitis is not a single disease nowadays. It is like a syndrome, I would say, wherein we need to address so many things together for a better outcome. And it is not a single disease. The spectrum of disease is so vast that it has been proposed nowadays into classification various endotypes of sinusitis. Every endotype has a different underlying pathophysiological mechanism. Every endotype. Yeah, yesterday we had allergic fungal sinusitis is a different endotype. AERD is a different endotype, wherein the basic malfunction at the molecular level is the patient is sensitive to aspirin, and that has to be desensitized later on to have a good outcome. So by and large, quickly in 2 minutes, again and again, since I was emphasizing this is an inflammatory disorder related to immunity. So how it is, what is happening at the molecular level in causation of sinusitis, and what is happening, at the research level to combat this phenomena, why medical treatment is important, and what is the cutoff line for the consideration of the surgical treatment. In next 10 minutes, until the patient is ready, I'll take you through. So our sinonasal immunity, is governed by the mucoepithelial junctions. The epithelial junction and the sinonasal mucosa is governing sinonasal immunity, and the things which responsible for the sinonasal immunity is intact epithelium, mucociliary mechanism, the mucociliary system. Whatever environmental challenges are trapped in the mucus, and then ciliary activity expel them to the nasopharynx, and then our sinonasal mucosa secretes thousands of varieties of antimicrobial protein enzymes, so many factors combating the challenges, environmental toxins, allergens, microorganisms, so many things they are handling with. And whatever thing which is passing through the sinonasal intact epithelial junction, it is recognized by the pattern recognition receptors, and then comes the role of adaptive immunity. See, these are the various proteins and materials secreted by the sinonasal epithelium to combat any individual, challenge coming to the sinonasal mucosa, and that's how this mucosa maintains the homeostasis and prevent the development of diseases. So what happens once the pattern recognition receptor recognize the challenge, then this leads to the secretions of liposomal proteins, interleukin, variety of interleukin 25 and 23 are responsible for initiation of the entire cascade. And then, innate lymphoid cells type 2 are activated, releasing the T2 helper lymphocytes. This results in release of further interleukin 4 and 13, initiating B cell response, interleukin 5 initiating eosinophil response, and basophil activation, and so all leading to the epithelial damage, secretions of eosinophil. So many factors are secreted, involving initiating the migration and survival of the eosinophils, and so on. The vicious cycle starts. So this is actually the pathophysiological cascade which has been recognized, and according to this, the targets are being identified to stop this cascade at that level wherever it starts. So accordingly, the targets are identified to block the pattern recognition receptors to block the interleukin-4, to block the interleukin-4 and 13, to block the IgE response, to block the eosinophil. So many targets have been identified, and these are monoclonal antibodies which have been identified. Some of them have, passed through the various, theories, researches, and various protocols, and are available in the market. And some of the indications in severe situation, probably because the same inflammatory mediators are responsible for asthma as well. So they have been used for severe asthma, severe even sinusitis in certain situations, and in times to come, when the safety, long-term safety, cost, and so many things are taken care of, they are going to be the future of sinusitis management rather than what we are doing today. What we are doing today is just, treating the clinical manifestation of sinusitis. By means of this, we can stop this entire cascade at the molecular level. Right now, at entire cascade level, at every point where these, monoclonal antibodies act, at every point right now, the only thing which works is the steroid. You give steroid, the response comes. But the question is how long you can give steroid. They have their own adverse effect. So this is the thing that when we should, why we need to understand this theory so that we can take a call that when the surgery is required and when not. See, this is the something I want to show. The options we have today. As I mentioned, corticosteroids are most effective in the present scenario, and they work at the at every level of the sinusitis pathophysiology or cascade. But we have our limitation, and what we can do in our maximal or adequate medical management, we can give topical steroid as they are more safe, way of giving steroids to the patient rather than the oral. Oral can be given as some time in between as a short course therapy, but never for long run. So right now, the only option we have is the steroids. As I mentioned, what the FAS is going to give. When your topical steroid, whatever you're given, what we call it is a maximal or adequate medical management, when the topical steroid are ineffective and we are not able to control the symptoms, we are not able to control the disease in spite of adequate medical management, wherein the core management is the topical steroid. When this fails, the next step is the sinus surgery, which we have been demonstrating since yesterday and today as well. And we have been world over why sinus surgery is being done, because the topicals are not able to control that particular inflammatory load, that high inflammatory load. So sinus surgery will reduce the inflammatory load. It will establish the physiology of the sinuses. It will make the sinuses healthy by establishing their ventilation and drainage. And the more importantly, now the topical steroid, which were unable to, handle the inflammatory load, now the topicals will be having access to the deep within the sinuses where they are required. So entire sinonasal mucosa will have now access to the steroid after the sinuses are wide open, and you can deliver by, in particular position by various means, various delivery devices. You can give access to the topical steroid reaching everywhere in the sinonasal mucosa. That is the goal of sinus surgery. So sinus surgery is a three-pronged goal. Never tell your patient that once you operate, you will be all right. Never. Surgery is the beginning of the treatment to switch from oral to topical therapy. That's the main goal of sinus surgery most of the time in eosinophilic disease. In future, as I said, targeted therapies are going to target the underlying pathophysiology mechanism, and that is going to be the future. So if somebody asks when to consider the sinus surgery, when your present safest treatment of the medical aspect, that is topical steroid, fails, then is the role of sinus surgery. It should be very, very crystal clear to everybody. And then the targeted therapy is the future. So that is how we can think of, when to operate, when not to operate. Satish sir, anything you want to add on to this concept. People would like to listen from you, hear from you. Anything you want to add on?
No, Satish, you have explained it so well that even I find it very educational. I think I must congratulate you on particularly your reading of the CT scans. What you're doing is on the DICOM viewer, it opens up a totally different perspective of studying the paranasal anatomy, particularly the frontal recess, and not only the frontal recess but all of the paranasal sinuses, and your ability to go back and forth. You wouldn't be able to do that on films. So I think this is a great, incredible way of understanding the anatomy. And your explanation on the endotypes and the phenotypes of the nasal polyposis is really very nice, very good. So let's start with the case now.
Sir. So, sir, since you get, difficult cases, referral from worldwide, I mean, everywhere, and you have been, treating this, you have been seeing this phase of, changing trends of treatment in sinus surgery or in sinus diseases for decades. So, in present context, how do you take a call for, surgery, when to end the medical treatment and surgery? You agree with our concept, or you have something, your way to consider the surgery in those cases?
I think it's like you mentioned, you never tell the patients that that the surgery is going to cure you of the nasal polyps or the sinusitis. This is like you also mentioned is basically surgery optimizes the nasal cavity or the sinonasal cavities for future topical treatment, and it helps.
Sir, can you raise a little bit of your voice, your mic closer?
Yeah, I'm actually my computer is not working, so I'm
Yeah,
using
it's
my
better now, sir.
phone.
Better now, sir. Yes,
Yeah,
sir.
yeah, that's right. Mhm.
So,
So this
Satish
one
sir
is
also.
eosinophilic disease, Satish.
Yes, sir. Yes, this is pure
So
eosinophilic disease, sir. Yes, sir. Pure eosinophilic disease, sir.
Mhm. And the patient has already been treated with steroids before the surgery, I guess.
Yeah, yeah. He has taken steroid courses several times, and this time also before surgery was given, and has been pure, has taken medical courses so many times, including oral steroids. Sir, nowadays, what we have been doing, see, India, we have, number of cases. The workload is, one of the decision making factor in our country, besides whatever science going on. By and large, any patient needing oral steroids to control his symptoms again and again, every 2-3 months needing oral steroids to control the symptom, is a candidate for us for sinus surgery, by and large. Because once you open up sinuses, you can switch over to the topicals rather than needing oral steroids to control the symptom. So, because in India, getting CT scan timely, preparing for the surgery with a maximal medical treatment as the symptoms comes under control, patient disappears. Many times, so many factors are there. So, by and large, any patient requiring oral steroids again and again to control his symptom is a candidate for sinus surgery for us. What is your opinion, sir?
I think I agree with that. Any patient, you can't give steroids. In my practice, I don't give them more than twice a year. And any
Sir,
patient needing repeated pulse doses of steroids is an indication for surgery. Yes.
sir. And I think you must be knowing, in certain countries there is a logbook of overall steroids taken during the particular year by the patients. They maintain it.
Yes.
It's not in
Yes.
our country here.
Mm-hmm. Yeah,
Is
it
in
is here in
Singapore?
Singapore also. Yes, it
Singapore
is.
also?
Yes, it is.
Yes. So in our country it's not so. So the indiscriminate use of steroid is prevalent amongst GPs. That is the biggest factor. We get massive disease cases for surgery. You know, these patients going to GPs, quacks, anywhere, they give steroid and the symptoms come under control very easily. The moment you start steroid, symptoms come under control. Even many of the physicians, in between do courses of steroid and symptoms come under control, and patient get away by these means from surgery, and they come with either complications or massive disease, osteitis, so many things later on which are difficult to deal with. That is the major reason we get advanced cases. So Ramesh, ready? So we are our case is almost ready. In couple of minutes we are starting the case. And once again, those who have joined, it's our pleasure today to have Dr. D.S. Sethi joined us for this session to interact with us, to give his valuable opinion. He is, I call him as a grandfather of sinus surgery in our country. He is the one who popularized the sinus surgery, trained so many, including me, in our country to spread this science. So in couple of minutes, we are starting now. Anybody has any questions or any suggestions, please feel free to interact.
Satish sir, Dr. Rajiv Pachauri also is joined.
Hello, boss. Good morning.
Good morning, good morning, good morning.
So nice to have him. I remember our COVID
Very
times
nice.
webinars with him. Unforgettable time it was. And all credit goes to him for all those webinars. It was his, maybe his idea, whatever that happened, all because of him.
No, it was combined effort of all of. In fact, Dr. Sethi was there, and he was very actively participated in that event.
Yes, sir. Sethi sir was a, father figure for those workshops. He always guided us.
I watch you to learn from you now, not to guide you.
Sir, that is your modesty, I know.
Yeah.
But I remember in 2004, your workshop in India, 2003-4, you did number of workshops. It's almost going to be 20 years from now, and
Yeah.
his teachings are still in my mind.
1997. 97 was the first one.
First one was 97. Yes,
K.K.
yes.
Ramalingam's, Dr. Ramalingam's.
Yes, sir. I knew you did their workshop for almost 15 years.
Yes, yes.
And that was the game changing in our country, because that time people had hardly any concept of sinus surgery. Then I remember my times in Singapore, in your lab, the way you would dissect the cadavers and demonstrate each and every anatomy, micro level anatomy, that time. For everybody, Dr. Sethi has organized or conducted more than 100 courses in sinus surgery worldwide, including his own hospital courses, the Singapore General Hospital courses, and many in India and abroad to popularize this science. And I have witnessed and learned out of them number of times. And the laboratory in the Singapore is one of the, I would say, state of the art, wherein he would dissect and demonstrate and give hands-on a fresh cadavers to everybody with the, HD cameras, navigation system at every station. And that is, something unforgettable experience, I would say. So I hope you are getting the endoscopic picture now.
Yes, we're ready.
this is your Marusol technique, huh?
And we are, for everybody, we are hoping Dr. Sethi to join us the AYCon 23 in Jaipur as a guest faculty, as an operating faculty, and for many things we are hoping, and very soon we'll announce it.
Always a pleasure to visit Jaipur. I love it. I love the place.
Sir, always a pleasure to have you and learn from you. Every single time being with you is a learning experience, always. See this picture after the initial decongestion, and that is the high deviation I mentioned. Can you see this?
Yes, yes, yes.
Yes, sir.
This is, I tell you, is one of the biggest reasons sometimes, in spite of a good sinus surgery done, for failure. One of the biggest reason. One can carry out the sinus surgery after decongestion through this high deviation. One can easily carry out. And you know what happens later on? Because of instrumentation through the narrow space, damaging the opposing mucosa, ultimately, invites synechia. And if synechia happens to occur, the entire purpose is defeated.
Yes, that's true. No,
It
that's
doesn't allow the topical to reach. So, कुछ pulse और कम. Sethi sir has a luxury of having TIVA there in Singapore for the anesthesia. I know. And sir, I want to know, are you still using cocaine for topical use?
No, no, no. I stopped using cocaine long time. I prefer to use epinephrine like you do. And we use TIVA not for all cases, but for some cases, yes, we use TIVA. Depends on anesthesiologist, so it's not for every single case.
Sir.
But since seeing you use epinephrine in Marusol, I've been using that for about more than 10 years now.
Yeah, because that time I've seen you using cocaine a lot.
Yeah, we were, because it was available here for official use, and then I think there was a sudden shortage. We used to get it from Australia, and then there was a sudden shortage, and we stopped using it.
So now it is the ADR which is being used.
Epinephrine is the decongestion that we get with the epinephrine and your patients, I would say, is much better than you get that of cocaine.
So overall, worldwide nowadays, the epinephrine is the standard thing used for decongestion. So I've been, as I mentioned, it's been years now since we have injected in the nose for any surgery. Solely relying on the topical, the pre-operative preparation, the intraoperative, anesthesia help, and this topical decongestion, but not doing any, infiltration to prevent the adrenaline disseminating into the systemic circulation and their adverse events. And topical gives equally good field if used properly, given adequate time and done properly. I told you, we are never supposed to pack tightly. We are supposed to apply the adrenaline to the mucosal surface to decongest the capillary. That's the only goal, not the tight packing, which is counterproductive to give, venous congestion. So on the right side, what we can see, the polyps, and what I'm using here right now is my Medtronic shaver to take away the polyps.
So 4 millimeters straight.
Yes, 4 millimeter tri-cut blade, sir. We don't see any landmarks, just polyps right now. Yesterday we had a case with a lot of polyps in the olfactory region. And we avoided, extensive debridement in the olfactory region to protect or to prevent fibrosis. And again, you can see the same situation looking like what we had yesterday. So this looks like the middle turbinate to me. See the axilla? See the axilla?
Yes.
That's the axilla, and this is polyposis medial to the turbinate.
Medial to the turbinate.
Yes, involving the olfactory region.
Good morning, Dr. Satish.
Good
Sorry
morning,
for joining
boss.
late. Sorry for joining late.
Arey, boss, no issues. I know. Coming all the way from the hotel after the breakfast, and it's a traffic time now.
And there is one-way traffic today. Some VIPs coming to visiting Bhagalpur. So all the traffic have been diverted.
So, boss, yesterday's similar situation like yesterday.
Similar situation like yesterday.
That's the polyp. That's the, this is turbinate. This is the disease medial to the turbinate responsible for the olfactory loss.
Yes.
And this is, distorted, looking like uncinate process.
So what are the chances of improvement in olfactory sensation after surgery in these type of patients?
Yes, it depends. See, yesterday we discussed, let me put my views again. This olfactory loss is mostly two types, either conductive or sensory neural. Conductive olfactory loss means because of the polyps, the smell, the fragrance, whatever is not reaching the olfactory receptors, giving olfaction loss.
Okay.
And that should improve once the polyps go down when the airway is established and the air starts reaching the olfactory receptors. Second thing is sensory neural means.
So this is conductive loss.
Yes, conductive. But you never know the sensory neural aspect.
No, yes, conductive olfactory loss.
Yes. So what happens because of the ongoing inflammation in the sinuses, which is spread to the olfactory mucosa as well, that inflammation involving the mucosa can result in sensory loss, and if it propagates further, the neurons has a sensory neural loss, which is something you never know. So what you can do to answer your question pre-operatively, because it is a question upfront asked by the patient many a times. Will my olfaction improve? And you don't have an answer, definite answer for that. And you can't even, so what you can do, if the patient insists in those situations, you can give a course of oral steroid for 10-15 days, telling him that if it improves with a steroid, that means it is reversible.
Okay.
You have a good chance, good prognosis as far as the olfaction is considered. So in that situation, you can do that. If it doesn't improve at all with the steroid course, with the polyp regressing, with the inflammation reducing, you can assume that the chances of improvement are less. Still, you can hope after the disease removal. And in that situation, you have to be careful surgically also. Yesterday, I, raised two important points. Number one, to prevent too much of debridement and giving, adhesions in the olfactory region, leave that hypertrophic polypoidal mucosa. Once your topical steroid goes inside later on, it will revert back to normal. So never ever become over, enthusiastic about removal of the olfactory region polyps. Number two, give a good access for the steroids to reach there. And the biggest problem there is the middle turbinate. So this is one of the indications where we almost always do a partial middle turbinate resection for uninhibited steroid reaching to the olfactory region. Satish sir, your experience.
I agree with that. I do that all the time, especially when there are polyps in the olfactory tract.
Sir,
So it is
Otherwise,
not
what can
very
happen
much.
is adhesion may form, and you'll find that the olfactory recess is occluded once more.
Can't crowd.
sir, see the olfactory region, sir, with this kind of mucosa. And I really don't want to, spoil it further by debridement or removal or whatever. I will leave it as such. And I'll hope the steroids later on should reach there and take care of this, part of the olfactory region. What I will do, that is my almost always a protocol in this situation. This turbinate, because of the polyps medial to it, becomes floppy. See this?
Okay. Yes.
This becomes floppy. If you don't do a partial resection, number one, and medialize it with bowdlerization or whatever, suturing, whatever, it will offset the steroid reaching there effectively, number one. And if you don't do, it may fall laterally to offset the access of the steroids to the ethmoidal complex. So it is always been in our practice. I don't know how much we are correct or not. Satish sir is more experienced, but this has been our protocol to do a partial resection to this turbinate in these cases when we have polyps in the olfactory region. Scissors. And in polyps, in this turbinate resection, mind it, as I mentioned yesterday also, always this turbinate is a great landmark. So don't try to chop it completely from the origin above, but rather leave
A small
a
part
stump
of
of the turbinate above for the orientation, because that is important landmark during frontal sinus work. See this. Wash. See, first we debrided the polyp, we didn't have any landmark. Now what we have seen, lot of disease in the olfactory region. The turbinate was floppy, and we did a partial resection, not complete chopping. That's the upper end of the turbinate. See this eosinophilic disease. See this mucin.
Yes.
This mucin signifies the eosinophilia. Means the steroid is the core treatment. Now, coming to the surgical steps, this looks like your the
Uncinate process.
distorted uncinate process. Once you have massive polyposis in the middle meatus, the uncinate is almost always distorted. And see this. This is the uncinate process. Reason being, this is the first, prominence anterior that belongs to the nasolacrimal system. That is the fixed one. And the second one is a mobile one. See this? The only mobile structure in the entire lateral nasal wall.
Is there any accessory ostia, Satish? Appears to be
Yes.
there is some accessory.
This is anterior fontanelle, you can say,
Yes.
which is anterior to the uncinate. The one which is behind the uncinate is the posterior one.
Okay.
And this accessory ostia must be communicated with the natural ostium when you carry out the sinus surgery, so as to prevent the mucus
Is it,
recirculation.
Is this accessory ostia congenital or it is just pathology, post-pathological status? What's your opinion?
Yeah, this is an anatomical, dehiscence, you can say. wherein the bone is absent and only two mucosal surfaces on either side of the maxillary sinus walls are there.
I'm
So
talking
that's
about, hello?
yeah,
I'm talking about accessory ostia. I'm not talking about fontanelle. This
yeah,
one,
that is what.
anterior one.
Yeah, so that is not an pathology, I would say. But once they are there, we must communicate with the natural ostium to avoid problems. Once you are contemplating sinus surgery, see, this is the region. This is the hiatus semilunaris. The bulla also is distorted, sometimes become atrophic because of the polypressure, and here is going to be the infundibulum layer there. So boss, what I am trying to say to your question, that once this accessory ostia is there, accessory ostia is not a pathology. Once accessory ostia is there, it must be communicated with the natural ostium during sinus surgery to prevent future issues, to prevent mucosal recirculation. Otherwise, what can happen? You have done a natural, widening of the natural ostium. The mucus coming out of the natural ostium can recirculate through the accessory ostium back into the sinus, and the problem can persist. Simple. How is the picture there?
Excellent. This is excellent.
See, the surgical field is important for everybody who were not with us yesterday. Surgical field is important. A lot of things to be done right, days or weeks before surgery. Since then, you have to do something to improve the surgical field. See, look at the surgical field. Now, the first thing, the infundibulotomy. See this? Reverse biting, turn it little down to stay away from the nasolacrimal system. And bite through the uncinate. Bite through, come anteriorly. Bite through, come anteriorly until you reach the hard bone. See this? Until you reach the hard bone is an important caution. See this here. What I can show you. This is my hard bone. This is the nasolacrimal duct. I realize the hard bone and stop there. Can you see?
Yes. Maxillary ostia is seen now. And there is a new book of rhinology, and I was studying almost 2 to 3, 4 months back. In that book, it has been mentioned that accessory ostia should always be addressed because it is also a cause of postnasal drip.
See, once there is a problem, it is not that the accessory ostia is the cause of the problem. These are two different issues. See now this middle meatal antrostomy.
Even suppose you are planning to go for septoplasty, you should check the do a nasal endoscopy, and along with septoplasty, check out whether there is an accessory ostium. Otherwise, even after a good septoplasty, your symptoms will not go back because it is a common cause of PND.
Yes, Satish sir.
Sir's voice is not very audible.
See, I'm widening this. There was some mucosal disease in the maxillary sinus. That's a remnant of the horizontal uncinate. And this is the region of the accessory ostia. With this, you can easily communicate. And this is the upper uncinate. This is the most important anatomy to me at this point of time. This is the upper uncinate. See this, the uncinate plate? The bony plate of the uncinate?
Yes, that's perfect.
Yes, you can remove the bony plate separately. And this is the upper part of the uncinate. And this is the time where you are closest to the lamina papracia. You are closest to the lamina. Look for the lamina there and define your lateral limit of the sinonasal corridor. That too in the beginning of the procedure. So that is important landmark. The upper uncinate is an important landmark. See, that is the important landmark. As you can define, see my lamina. Can you see the lamina papracia?
Yes.
That is the lamina papracia. You can reach lamina in no time. See this? See the middle metal antrostomy
Yes.
and lamina in no time. So that is our first part of the surgery. Every time when you do, define your lateral limit. This is a challenging frontal sinus on this side, I told you. If you have seen the CT scan, this has all difficulties one can think of. And we have to, take care of that and go accordingly and follow the same. I told you yesterday, whatever is the anatomy of the frontal, keep your beak as one of the principal landmarks, which is never going to change. Beak is something which is never going to change as a landmark. Give me 70 degree now. So I am switching to 70 degree here.
Hello.
Yes.
The audience wants some external views. How your assistant is working with the OT setup while handling the 70 degree.
So
Dinesh?
can somebody? See now, the most important thing here. See, medially is the disease in the olfactory region. See that?
Yes.
This is your stump of the turbinate, which you don't want to disturb. Hello?
Hello?
Medially, the stump of the turbinate, which you don't want to disturb.
Yes.
And just medial to that, first I am opening up the axilla
Yes.
and defining my beak.
Beak. Searching for the beak.
Stay far anteriorly to define your beak.
And this beak is not beak. This is very strong beak. Sometimes this.
The beak is the most important landmark, I tell you. And that is my beak. See that beak?
Yes, very tough.
Yeah, let me show you. Let me clear the picture and show you. Much better view. Let me decongest 120. Interesting frontal sinus scenario. Medially, this is all olfactory disease in the olfactory region.
Yes.
That is most important to be left undisturbed.
Okay.
Can you see the beak there?
Yes, yes, yes. Very, very clear.
Can you see the beak there?
Yes,
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 right.
This one is a beak.
yes,
See there up
yes.
where my suction is the beak, and this is where the beak is ending. See everybody,
Yes, yes, yes.
this can never change. See this beak, this one. Give me. Again, we'll show you through the debrider. Can you see the beak? Hello?
Yes. I see that. ये big था वो.
Can you see where the beak is ending?
Yes, 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 yes. Very, very clear. Now we are almost in the frontal, most probably. I have not seen the.
Beak is the single most important landmark. That is your frontal sinus. See that? Now we have to see a lot of other things here. See that the frontal? 60. Hello?
Yes, yes, yes.
Could you see the frontal in no time?
Yes.
So easily.
The same question will you keep on coming. What are the other things that matters most in the area of frontal sinus?
Now see what I'm showing.
Yes.
I remove this party wall behind and laterally. What is going to be there in this case? I had shown you on radiology. See the frontal above?
Yes.
See the party wall, remaining party wall.
I was absent during your radiological session. I came late.
Okay. So those who were present, I showed you the supraorbital cell. And that is the supraorbital. See the supraorbital cell? Hello?
Yes, yes,
Yeah.
yes.
You can see very clearly.
That is the supraorbital cell here. This one laterally and above. And this is the party wall between this and the frontal.
Everyone should have very good correlation with radiology.
Yeah. You know,
Unless we know
give me
radiology,
the
we cannot
giraffe.
do good surgery.
Giraffe. Huh. See the two cells together, the frontal sinus and the supraorbital cell.
Cell or recess?
Pardon?
It is cell or recess.
The same thing I told you.
Same thing.
Yeah. If it is too deep, people call it cell. If it is a very shallow, it is called recess. So it is not different. It is, let me show you better everything there. Wash. Give me wash. I'll give you a wash, mop, and show you the anatomy there. See, frontal, you must never forget how I reach so easily. Beak. Suction karna. Since yesterday, you have been seeing in every case all difficult frontal. The thing which is most reliable, taking us into the frontal, is the beak. I'm just giving it a wash, mop everything, and show you so that you can get to know easily where exactly I am. थोड़ा धार लगाते हो हमारी माँ. Just a minute, just a minute. What?
Are you using hydrodebrider nowadays?
Yes, yes. I use hydrodebrider. Once you have a thick secretion, not coming out easily, fungus. Now, see this. Two cavities in different direction. See this, everybody? This laterally, this one going up. This is supraorbital cell. See this? Can you see?
Yes, yes, yes. Big, big, big. Big.
This is our frontal sinus. सही करो. सही करो.
ए यार वाला तू गड़बड़ वाला हमको दे दियो.
Section is blocked.
Hello.
Yes.
And how to avoid bare bones? How to avoid matlab mucosal strapping?
Yes, I mentioned yesterday, and you know it well. Use sharp instruments.
And
Never pull the mucosa. Micro debriders, through biting are the important tools to avoid that.
So how many times we can use these blades, micro debrider? Should we use fresh blade in every case, or should we
Ideally,
use
ideally.
it? But the cost will go very high. And which type of the blade you use most commonly used blade by you? 0 degree?
You know, boss, I tell you, it was 2004. Is Satish sir there?
Yes, he is there.
Yes, Satish, I'm here.
Yeah, sir, I was telling them about 2004 when about the Singapore General Hospital. So there, even if you open the blade, even if you don't use, they will throw it. Am I
Okay.
correct, sir?
And here people used to keep
Hello,
you're
sir.
correct.
using.
Am I correct?
Yes, you're correct. Yes, you're
And
correct.
I would always tell, sir, where do they throw? I would always ask this thing, where do they throw? I want to know. Even if you have used only once, just single rotation, they would throw.
There's a long queue over there.
Yeah, that's right.
Actually, this question was specifically designed for if people are using same blade for years together.
That cannot work. Not only blade, even the machine will not work. That will ruin the machine.
Yes.
Satish sir, in this case, you can see the supraorbital cell
Yes,
and the
I saw that. Very nice. Very nice.
Frontal
And
there.
I like your,
Excellent. Excellent.
and I like your frontal beak as a landmark. You know, it's make it look very easy. But actually,
This is to
things can go
simplify,
wrong.
sir.
Yeah, it is simplified. You're right.
Because even in the multiple revisions, the beak is almost always
It
there.
is always there.
Right,
It's a
Zira.
landmark that is not lost. So it is a fixed
So-
landmark. I think just like you have the roof of the maxillary sinus as a fixed landmark, this is a fixed landmark that is always there to help you, to guide you.
And this is the party wall between these two. See this?
Yes. Yes.
Sir, this is my side biter for frontal.
Okay.
This is frontal side biter.
Okay.
Yeah.
Made by Santosh
Yes.
because
You can-
cost of
You
hospital
can-
instruments are very high.
Yeah, you can get it ordered and according to your requirement. But this is a good instrument.
Is it of a storage or this one?
I don't remember. See now, I am removing the party wall more and more to widen the frontal sinus drainage.
These Santosh surgicals are making very good instruments, good quality instruments, especially for FES.
See now the frontal up there.
And it's cheap also.
See the true frontal sinus above there.
Yes, yes.
Wash. Give me a wash.
Still it needs more.
So
clearance.
that the complexity in this case for the frontal was not very big. The supraorbital cell encroached from laterally, narrowed the frontal pathway. And see now we have the
Yes.
frontal as well as the supraorbital. Now what I will do further to widen this reverse, I will flush this, the posterior table of the frontal with the ethmoidal roof.
Okay.
This is important as this supraorbital, the suprabular cell sometimes is left there, untreated, unaddressed, and can be a big problem. See this here.
Yes, yes, yes.
See this. This is my reverse, or I would call adenoid blade, without any fear of injuring the anterethmoidal artery because I am working far anteriorly.
Yes.
This is the reverse blade. See now? That
Yes.
was the intersinus septal cell medially which was communicating. That was the frontal sinus, and what I have, removed the party wall is between the supraorbital and the frontal sinus. Now it is much better. You can see very well now all the three things and almost mucosalized. Can you see?
Yes, 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 yes.
And see, this is where this posterior table flush with the
It's mud roof.
ethmoidal roof. Can you see?
Yes.
So we have this wide opening now, keeping the beak as a principal landmark. See this beak again. We can, if you see retrospectively, this is your beak. The moment, see your sagittal section, where the beak ends, the frontal sinus starts.
Mm.
See this. Body. See this. Again, for easier understanding. See, this is axilla.
Yes, yes, yes.
Following the axilla, you can find the beak. This is the beak, that is the thickest bone. See this?
Yes, yes, yes.
Follow the beak from anterior to posterior, where it ends in the frontal.
Okay.
This structure being so big, this supraorbital, this being so big here, narrow the frontal outflow from laterally. That was the small, shallow, this thing here medially was the intersinus septal cell, which is communicated well here. See this here?
Yes, yes, yes.
See this? Here
Yes.
it is communicated with the frontal sinus. I can show it better a little bit.
Mucosa is getting a strip.
Yes, yeah, just to show you. Okay?
Yes.
So this is how you can see all the three things together. Those which were, resulting in frontal sinus issues can create problem later on. Only thing what you can do is section. widen, widen and widen. There is no limit of widening in terms of millimeters or centimeters.
Yes.
No point in measuring those.
One end to another end, maximum possible.
To the limits. To the limits. See, I will open up this cell further. I'll show you interesting. The ethmoidal skull base now. Ball problem. Let me show you the ethmoidal skull base now. See, this is the cell.
Yes, yes, yes.
I am going reverse. See this. Any movement away from the skull base is always safe.
Always true.
Reverse. See now, flushing the posterior table. Once again. See, flushing the posterior table.
Yes. See how big the frontal is, the drainage pathway. It's not about the frontal sinus. It is about the drainage pathway. And this disease medial to it is left undisturbed. Okay.
So that is my final frontal sinus drainage pathway.
Drainage pathway.
Give me a marrow cell. That's the final drainage pathway. Taking care of all the cellularity there to give a common drainage pathway to all these cells. Because all these cells require for their health the ventilation and drainage. Now the entire area will be drained into this common drainage pathway.
Yes, yes.
See the common drainage pathway. Supraorbital, frontal, and the intersinus septal cell above. Can you see very clear?
Yes, yes, very wide.
Satish sir is a huge series of frontal sinus, pathologies. He treated endoscopically. Now, having done this, we have not even discussed about the intraethmoidal artery. See this? We have not even discussed. What I told you, the intraethmoidal artery passes through the roof of the post-ethmoid in the posterior most part. See? That is leaving the frontal sinus and beginning of the post-ethmoidal, anti-ethmoidal roof. Can you see there? Hello?
Yes.
So, in order to see the intraethmoidal artery, go there, 40. In order to see that, we have to remove this bulla. And this technique of intact bulla was propagated by none other than Dr. Sethi. We discussed yesterday also. See, our ethmoidal artery, for everybody, don't get terrified from the beginning of the surgery or while doing frontal sinus work. Ethmoidal artery doesn't pass so anteriorly. It passes through the anterethmoidal roof in the posterior most part of the anterethmoidal roof. And anterior to that comes the bulla, which goes above and get attached to the anterethmoidal roof anterior to that vessel. See, this is all mess here because of the disease. Can you see here?
Yes, yes.
Everything messed up because of the disease. See the thick wall of the bulla.
Thick wallness.
I'm removing. My intraethmoidal artery is behind this. That is behind the anterior attachment of the bulla onto the skull base. And that is right running along the skull base. You don't need to terrify all the time. See this? This is all mucosal disease which has messed everything there. See, all this mucosal disease. Massive. See this? My lateral limit, this is lamina, laterally, can you see? I'm working with a 70. Now reaching toward the skull base. See at this point. That is behind is the skull base, behind and above. See this thick osteitic. See this?
Very thick bone. And you should never try to cut with the divider this type of bones, because divider blades would get damaged.
It may ruin the blade.
Yes.
So this is all osteitis. Osteitis is nothing but, I would say, depot of cytokines in the bone. With the inflammation which is extended to the bone, now, one thing I want to clear you here. Give me reverse. Here is. That is your supraorbital cell above.
Yes.
Where the immediately caudal to the supraorbital cell. See, I am following it from above in the same way.
Yes,
You will find the intraethmoidal artery.
Yes.
So here, yes. See this. See this. That is the supraorbital cell.
Yes, yes.
Reverse.
Large supraorbital cell.
I want a reverse one. I will use a.
Can you call it
blade.
suprabular cell also?
Yes, that is the extension of the supravalvular cell. That pneumatization, when extends laterally and above the orbit, is called supraorbital. See now. That is the supraorbital cell. See, I am using the skull base blade, the reverse one.
Yes.
Here comes the anterethmoidal artery canal. Here.
It is
Not
almost
very
in the
prominent.
root.
Not very prominent in this case.
Yes.
Not very prominent in this case.
Radiologically, once you see.
So how you will manage if there is a tear in this artery at this level?
No, it's not. If it is prominent, it's fine. You have to be careful. It's not that you have to necessarily bring out the artery.
Suppose a tear in the artery or the bleeding from that artery during your procedure, then how you will manage?
Yeah. So I mentioned yesterday, bleeding from the artery is never a big concern. Let me give me 0 degree. I will mop the area and show you. Bleeding from the artery is never a concern. You can take your section bipolar and coagulate. The concern is on either side If this artery transected laterally close to its exit from the orbit, completely if it is transected, it can retract into the orbit and can keep on bleeding and give intraorbital hematoma. That is a concern. Concern is not the
Bleeding in the nose.
bleeding. Give me patla the next section. Section will patla. Let me mop, clean, and show you this. Now I am with 0 degree again. See the frontal sinus area?
Yes, 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 yes.
See how much of the disease, see that? How completely chalking this region, the disease process with no landmarks. Remember?
Yes, 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 yes. Hmm?
Brighter.
No, वहाँ पे नहीं करता है ना, वहाँ नहीं करता.
And see on this side, this is the disease in the olfactory meatus, olfactory recess. See that?
Yes.
Which we are not, leaving it like this. Skeletonizing the limits. This was the cell. This is the lamina. Skeletonizing the limits. Skull base. That's the frontal above with the 0 degree. See that? Everything is skeletonized. At the anterethmoidal roof, the artery is not very prominent. Can you see?
Yes, yes. Very clear pictures.
Give me wash section. Just let me
Is there any more case of face for today?
just force.
Any more case of face? 4 more cases
Total 4 cases today.
for face.
Yes.
In next case, we would like to see Caroline's window.
Okay, that was described by Richard Harvey.
Yes, yes. But who was Caroline? I don't know why. In one of his video, I came to know about that Caroline's window.
So Caroline's window is nothing but an access through here directly into the frontal sinus.
And all the surgery can be
See here.
performed with 0 degree.
Yes. So see, those are the ways to earlier.
Earlier
Professor
from
Peter Wormhole brought the
Wormhole,
concept
yes,
of
yes.
axillary flap.
That was
See,
actually, yes.
Nothing can replace 70 degree. I tell you.
Okay.
Nothing can replace 70 degree. You can go right into the area. See, we went right up into the frontal sinus, saw everything. Nothing can replace that. See, after that, see our region. See the frontal up there with a 0 degree. See the frontal up there. Hello. Hello.
Yes, sir.
Did you see this?
Yes, yes.
Now, another thing I would like to have opinion from Satish sir. These days, a new concept that really impressed me is the 0 degree visualization of the driller. 0 degree visualization of the frontal sinus. Hello? And
Yes.
that has really helped me, I'm really impressed. Reason being, you can push your topicals much better into the frontal sinus by your the way the positions you tell you the patient. It can be forced much
Anyone who
better.
wants the microphone?
Hello? Let me show you here the concept of 0 degree visualization of the frontal sinus in this particular side. Now we have seen the frontal sinus up there, What is inhibiting? See this beak? Hello?
Yes, sir.
This is 0 degree. And we have been able to see the frontal sinus above. Can you see there? A
Yes,
glimpse
sir.
of frontal sinus.
Yes.
To make it better, to make your topicals reaching better. What I am showing here now is something interesting. See this, I am removing can you see this mucosa I have removed?
Yeah, entirely mucosa removed.
A little bit of keration. Is Satish sir watching?
Yes, Satish, I'm here.
Yes, sir.
Sir, this is to improve the topicals reaching to the frontal.
Mhm.
See this what I am doing. I removed that mucosa from this axillary bone. See this axis?
It is
Yes,
increasing.
very nice.
So what we have seen, the patients who have massive frontal disease requiring a proper high volume irrigation, eosinophilic disease in the frontal, what you can do, yeah, just little bit of the drilling of the axilla, not the beak, not the beak, and you get a free flow into the frontal sinus of all this, irrigation materials. Pani badana, pani badana.
This is stylus.
Yeah, see this, it won't take more than 2 minutes. It won't take more than 2 minutes. I'm removing this part of the projection of beak, not the beak completely.
Canal wall down.
Give me wash and debrider. Now you see the 0 degree visualization of the frontal. It's not about visualization, but it definitely helps your irrigation reaching much better into the frontal. Definitely we have observed, and there is no harm in doing that. Particularly in cases where there is a massive frontal disease demanding high volume irrigation into the. See the access to the frontal now?
Yes, it has increased a lot with 0 degree.
Sir, can you make out the difference?
Yes.
So this is
Satish,
yes.
Satish, I have a lunch appointment. I have to stop out for a while. I'll join back
Yes.
later, okay? Okay.
Yes,
thank
sir.
you.
Yes. Please, thank you
Thank
for sparing your
Thank you.
time.
No.
Okay, thank you,
Yeah, I'll
Satish sir,
come
for
back.
being with us.
No, my pleasure, my pleasure. Thank you.
See this 0 degree visualization of the frontal.
How to deal with these bare bones?
Yeah, that's once you irrigate, your steroid goes is never a problem. Problem of cicatrization, granulation, restenosis would come in the past when steroid dosing was not in a practice. Now with the steroid dosing in practice, see now what I have done this simply open the access for the topicals to go directly into the frontal. That's it. Can you see?
Yes. And what's
That
your and how do you advise for the irrigation? Is there any proper position or just nasal wash? What
Yeah,
we used to
there
say
are 2 positions, standard positions. We always propagate is lined head back or prayer position.
rare
Bending forward or lying head back. Both allows the solution to reach effectively into the frontal.
there is also namaz position.
Yes. See this? Now this area is opened up so widely. Can you see?
Yes, sir.
Hello.
Yes.
Now, lastly, for the post-ethmoid and frontal, you have already seen this maxillary line. See this? Now, I can easily go into this region of the maxillary line. See this?
Yes, yes, yes.
Yes.
आ गया.
See this massive disease. And once I remove this, now you can see the superior turbinate coming into the picture.
Yes.
This part of the middle turbinate, this flat bone, the middle turbinate. Now see, this is your superior turbinate. Can you see?
Yes, sir.
That is your superior turbinate here, where I am. Now in the maxillary line, go medial to it. Go medial to it and see this. I am in the sphenoid. No time. See this?
Yes.
Once you have seen the sphenoid, see the sphenoid sinus? Now you can carry out the rest of the job easily. Once you have seen the sphenoid, you can carry out the posterior ethmoidal work like anything. Staying anterior to the frontal ostium. See, this is the frontal.
Very nice. Very clear.
Sphenoid ostium, staying anterior to it. You can remove all these septations without any issues. Anything anterior to the sphenoid sinus ostium is safe. That's the ostium. Anything anterior to it is always safe. Plus lateral limited lamina. All these things staying anterior to it. All this you can remove. Staying anterior to the sphenoid sinus ostium. See,
Yes.
it gives you an opportunity to work freely, fearlessly. See this sphenoid sinus?
Yes, yes.
And we are not
Yes.
supposed to go behind like this here.
Okay.
Now, see the skull base all the way.
Yes,
See the
yes.
close up. All clear. The beauty of the debrider is preserve the mucosa. See that?
Yes.
Now, how to widen this sphenoid? This bone has to go. See this?
Yes, yes.
Through biting. And widen. The last thing left is the widening of the sphenoid sinus. Section. Sphenoid. See, that is the sphenoid sinus.
Yes,
And this is the bone that needs to widening. And I am using the Karl Stoss through biter.
true cut. Beauty
Widening
beauty of this true cut whiter is that it absolutely prevents mucosal injury.
Yes. Very safe tool. Doesn't pull anything. See the interior of the sphenoid?
Yes.
Carry, son. See, this widening should be adequate.
Widening
Now-
up to the limits.
See the anterior wall coming.
But
It
we
is-
should always avoid widening in the lower side because
Not lower side. You may take
anterior wall of a sphenoid, you can suppose.
yeah. It is the anterior wall which requires widening laterally. Right. Now see how much the sphenoid is widened. So this patient had a massive eosinophilic disease. See this?
Yes.
What an interesting case again. Thanks to Farooq for keeping all the variety. If you don't remove this anterior wall completely, you can leave many cells related to it anteriorly. Now see the complete interior of the sphenoid. What is it? See the sphenoid sinus?
Yes.
How much work it required? What is it? वो लगा 40. I need a 40 blade. See the entire skull base. See the entire skull base. See in your OPD, you can see with your 0 degree the entire work done. You can follow case very effectively with your 0 degree. And that's the final touch. Final touch for this side. See this? The panoramic view. And this disease in
Yes,
the
sir.
olfactory region is not disturbed. Can you see?
Yes, sir.
Over there. Yep.
Sir, just focus one's olfactory area. Where
Yes.
the disease
Going on.
or mucosa is the left as such.
Yes, see this. See this olfactory region? Can you see this polypoidal mucosa?
Yes, sir.
See the panoramic view with a 0 degree.
Yeah.
And this we additionally did the 0 degree visualization of the frontal. For that, we widen the access for the topicals to go inside. Can you see?
Yes, sir.
Lamina laterally all the way,
Yeah.
olfactory region medially,
Yes.
anteriorly beak, and posteriorly skull base.
Yes.
Keeping everything in view, right, you can irrigate, and this is about the sinus surgery on this side. See this? There's a complete comprehensive work on this side.
Sir, finally you will pack with steroid soaked gel foam,
Merocell.
Merocell.
That's the remnant of the middle turbinate stump. See this here. See this. Now moving to the other side quickly. You have number of cases lined up. See the polyps on this side and this high deviation. Straight them. Wash kar. See the massive polyposis.
Yes, sir.
See the eosinophilic material. This is middle turbinate.
Yes, sir.
And see this lower part I can remove. See the polyps.
Yeah.
Upper part I will not disturb. See that? And see the turbinate floppy. Same story again. Can you see?
Yes, sir.
So these are the patients who have olfaction issues with eosinophilic mucin and the polypoidal disease occupying the olfactory cleft. Which has pushed middle turbinate medially, and middle turbinate is actually sandwiched between the polyps on either side and becomes unstable. See the state of the middle turbinate.
Yes, sir.
See this. That is the state of the middle turbinate. And see this high deviation.
Sir, you will remove deviation also. That
Yes,
bony
yes.
projection.
Yes. So these are the complex patient with eosinophilic disease, complete whiteout involving all sinuses with some abnormal cellularity, complicating further as a surgical challenge. And we all know sinus surgery requires the margin of safety is less. The critical structures all around are in close proximity. So you have to be very careful in that all the time in terms of preventing complications.
And the prior to removal of the polyp, there was no anatomy visible.
Yeah. Now you can see everything. See that? Now this uncinate as always is distorted. That's the uncinate,
Yes.
the mobile uncinate. See this?
Yes.
Everted because of the polyps. No, push करते रहना हल्का फुल्का करते रहना. See now, quickly you have seen the same thing on the opposite side. I can finish it off quickly. You have seen this repeatedly since yesterday, couple of times.
Yes, sir.
So we'll go little faster now so that we can do more and more. Feel free to ask me anytime if I don't speak much. This
Sir, you are
patient has a massive maxillary sinus disease.
Sir, you are using 0 degree.
Yes, yes. This patient looks like having massive maxillary sinus disease, and we'll do something to address the maxillary sinus more effectively. See this polypoidal mucosa in the maxillary sinus?
Yes, sir.
When you have a maxillary sinus disease and you are not able to address it effectively from the nasal side, you have other ways to address it in a simpler manner. Let me show you. Hmm? See, massive disease in the maxillary sinus.
Yes, sir.
Well, I don't know, chota LR cell. Yesterday we saw a small LR cell. Now to maxillary sinus, here we have question what all we can do more in case we have a difficult inaccessible disease in the maxillary sinus, far anteriorly and far laterally. What can be done simply? Let me show you.
Yes.
Right. Let me show you here. It won't take more than a minute. And we have a complete 360-degree access in the maxillary sinus. उसके बाद जेन ले जेन ले लेता है हम टॉन्सिल कर देना उसका इस टेबल पे जेन है ना करा दो Hello.
Hello, sir.
Yes, to address the difficult maxillary sinus disease, what can be done? Simple. एक जना आना पड़ेगा.
Caldwell approach, sir.
Yeah, I will go sublabial to put my micro debrider. Now, where to put the debrider in the sublabial? To the thin anterior wall of the maxillary sinus.
Above canine, sir.
Yes. So, see simply in the mid-pupillary line. See that?
Yes,
In the
sir.
mid-pupillary line, go a centimeter above the gingiobuccal sulcus. Hold this. Hold the telescope. Here. In the mid-pupillary line, a centimeter above the gingiobuccal sulcus, and you are inside the maxillary sinus.
Just what we do in Caldwell approach, sir.
Same.
Yes. Yes.
So let's see where we are. I pushed. Can you see my cannula?
Yes, sir.
Let me remove the marrow cell first.
And you will use the angle scope, sir, in this case.
Yes, I will be using 70-degree wash करना है.
Yes.
70-degree from the nose
Yes, sir.
and red 40 from the opening. Red 40. 70. And we'll have a complete 360-degree, freedom to
It's
work
always
inside.
helpful, sir. Yes, sir. This approach is always helpful for anterolateral diseases.
So, number one, will not put through the cannula. But इसको बंद कर. Will not pass it through the cannula. Hello?
Yes, sir.
We will not pass it through the cannula
Yes, sir.
directly to get more freedom. Yes. Can you see my debrider inside?
Yes, sir.
Being red 40, it has a complete freedom. It can somersault inside
Yes, sir.
and go everywhere to each and every nook and corner of the maxillary sinus. See this?
Yes, sir.
This from the inferior medial, superiorly,
Yes, sir. We can
laterally.
touch all the corners.
Yeah. See the floor, medially, anterior wall. See everywhere?
Yes, sir.
And the maxillary sinus is much better now.
Yes, sir.
And see, it is going directly through the opening,
Yes, sir.
not through the cannula. See this? And we can remove it.
Yes,
That's
sir.
it.
Yes, sir. Yes, sir.
Your maxillary sinus work can be done much better. See this?
Yes, sir.
Entire sinus is clear.
few polyps in the anterolateral wall, sir.
That will subside. Now you have a full access
Yes.
with the topicals to go inside.
Sir,
Major disease you have removed, you don't need to remove each and every mucosa.
yes, sir. That will subside with steroid.
Yes, so as the topical steroids penetrate, it will subside
Okay, sir.
without suctions.
Sir, another approach is through inferior meatus.
Yes. See, this is more straightforward.
Yes, sir. It's a direct head-on.
Yes. Yes. Without any morbidity. Again, the mucosa which you puncture through the trocar, it heals without time. So the maxillary sinus work is done. Now coming to the frontal sinus work. Before that, we have removed the lower part of the uncinate. We have removed the part of the upper part of the uncinate.
So there is a spur in the posterior part of the septum. How will you address that? Is it required?
Not very strictly, but yes, we will do some high deviation correction.
Okay,
We'll
sir.
take care of that also.
Okay, sir.
बंद हो गया.
Very sharp spur, sir.
Yes, but it's not bothering. See the maxillary sinus now?
Yes, sir.
Now coming to the, what is it? This region, the roof of the, see that is roof of the maxilla?
Maxillary, yes, sir.
Yes. Now this is upper part of the uncinate. See this?
Yes, sir.
And immediately you reach to the medial wall of the sinonasal corridor. That is lamina pepracia, lateral
Yes.
wall of the corridor. See, that is lamina pepracia.
Yes, sir.
That is one of the most important landmarks. See this lateral wall.
Yes, sir.
This is your terminate. I told you we will take care of this.
Yes, sir.
Do a partial resection. That is the upper part.
Yes, sir.
I'm going quickly. You have seen this number of times now.
Yes, sir.
See this. I've opened up the axilla.
Yes.
At the end of the day, we are going to remove this turbinate. That's your lamina pepracia. See that?
Yes, sir.
All the way.
I think, sir, patient has not taken the proper medical treatment.
No. No. Back the way. Now we'll switch over to 70 degree and show you the frontal sinus work. We have a small type 3 cell on this side.
Yes, sir.
The septum, see the massive disease medial to it, this turbinate,
Yes,
and
sir.
disease medial to it. So I will take a part of it. So just this is part of the turbinate.
Yes, sir.
And now is the time to switch over to 70 degree. See this?
Yes, sir.
We'll identify the beak
Yes.
as usual. What enter? The next case is going to be JNA,
Yes,
juvenile nasopharyngeal angiofibroma. Not very
extensive one, sir.
not extensive, limited one.
Okay, sir.
See that?
Yes.
Give me back. See, show you the landmark, how to get into it. Now, first of all, I'll define my beak. Simple. See this?
Yes, sir.
Good picture?
Yes, sir. Good, sir.
Now, first of all, I will define my beak. Here's the axilla. Go along that and define your beak.
Yes, sir.
That is your beak. Can you see?
Yes, sir.
Let me make it very, very clear for you. You will never forget in life.
Yes, sir.
Forceps. Oh. See, for those who are interested in the frontal sinus work, to simplify, open up the axilla and define the beak. Can you see the beak there?
Yes, sir.
That is a projection of the beak, down projection of the beak, and beak is up there.
Yes, sir.
See, the beak is up there,
Yes, sir.
and the projection of the beak.
Yes, sir.
And if you go underneath that,
Directly into frontal.
yes. No ifs and buts.
Yes, sir.
See that? That is my avenue.
Sir, you said in one of the conferences that frontal sinus is the most easiest sinus to approach.
Believe me,
In your
Believe
hand,
me,
it's
it's like a
okay,
box.
sir.
If you follow the concept, it's like a box.
Yes, sir.
And it is because your 70-degree makes your life easy, you know. All the time your limits are in your view.
Yes, sir.
See, my limits terminate medially, see this?
Yes, sir.
Lamina laterally, see this?
Yes.
And the beak anteriorly, and the frontal is waiting for you to go in.
Just cut the ribbon.
See this? See this where the beak is?
Yes, sir.
Down projection of the beak there.
Yes, sir.
I will remove that later. And you are directly onto the frontal. See this?
Yes, sir.
Right. And now I am going into it. Once you have a type 3 cells, thoroughly open up the space along the terminate. See this wide. Can you see?
Yes, sir.
6, 7, 60 there. Give me a mop. Give me a mop to show something very clear. See this. Let me keep it for a minute. Decongest it thoroughly. There's a good situation to explain.
Sir, it's oozing a little bit because of the infection or BP or pulse.
Probably inflammation.
Because infection and inflammation.
Yeah. See this now.
Yes, sir.
See the beak there up? Very clear?
Yes, sir.
Everybody see the axilla and see the beak.
Yes, sir.
Now,
That is
I will
agar
go
cells.
inside. Now, I will go inside medially. See this?
Yes, sir.
Medially, that is your frontal sinus opening.
Okay, sir.
120. Can you see this?
Yes, sir.
What is this laterally which is narrowed the opening?
Agar cell, sir.
Type 3 cell I showed you.
Okay, sir.
Remember the CT.
Oh,
So this is the opening for the frontal sinus up there.
okay, sir.
See, that is the frontal sinus up.
Beautiful, sir.
See there up, that is frontal sinus.
Yes, sir.
See there up?
Yes, sir. Beautiful, sir.
What this thing which is narrow the frontal from laterally?
A type 3 cell.
Yes. Simple. See this?
Yes.
And I will get rid of this cell. And you see then how wide is the frontal sinus opening.
Yes.
Right now, this is the only opening we have.
Okay.
See this secretion coming out? That is the only opening we have for the frontal now. See this?
Yes, sir.
And now, what I'm going to do, we'll go behind this cell. See this cell?
Yes, sir.
Divider. See, I have fractured that cell.
Yes.
That's the upper remnant of the cell. Little bit of the widening. See now.
Yes, sir.
See the frontal sinus now opening?
Beautiful, sir.
That cell is taken off.
Yes. Sir.
Now, this projection of the beak, see down projection,
Yes, sir.
is the obstruction. What is
Yes.
the best tool for that? Anybody from the audience? To take away that down projection.
Carrison, sir.
Which carrison?
Articulated punch.
This
Articulated punch.
articulated punch. See this? See this?
Yes, sir.
To take away this everything. Some more. See how the opening has widened.
Yes, sir.
See, the beak is up there. That was the down projection which I have taken off.
Yes, sir.
Let me show you. See the beak above?
Yes, sir. Almost in a straight line now.
Yeah, I have removed the down projection.
Yes.
And now you see the interior of the frontal sinus. See the interior of the frontal sinus now.
Yes, sir. The lateral opening is supraorbital.
No, not supraorbital is behind.
Okay, sir.
That was a shallow recess on this side, nothing significant.
Okay, just a recess.
Yeah, shallow recess.
Okay, sir.
Dr. Satish, what are your indications to put a stent in this frontal sinus?
What?
A stent in the frontal sinus.
Never. Don't need. Do a complete job.
Yes.
Don't need stents or anything like that. That is purely a monkey business, I tell you. Those who do not do a complete job of the frontal sinus, fear factor. That's why these workshops are to shatter your fear. See, widen the frontal to the limit. What will a stent do? A stent will widen to the limit.
Again.
Widen surgically. See this.
Yes, sir.
Can you see the opening of the frontal now and see the beak? Everybody, what we have been discussing since yesterday, the most important landmark, see in every case, it will never change. You have to understand for the frontal only one line.
Yes.
Where the beak ends posteriorly is the frontal.
Yes, sir.
See this was the axilla.
Yes, sir.
Anybody can identify the axilla
Yes,
easily.
sir. Yes, sir.
Follow the beak, follow the beak, follow the beak. Where the beak ends is what? Frontal.
Yes, sir. It's about
this?
1 centimeter from axilla, sir. The
Yeah,
frontal
1 to 1.5 centimeter depending upon the thickness, which is variable.
Yes, sir.
So where is the difficulty? Where the beak ends is the frontal behind.
Yes, sir.
Same thing again and again we are seeing. The
Yes,
only
sir.
thing, the cellularity can be different, that you can see on the CT scan and accordingly join them.
Okay, sir.
Supraorbital, whatever cell, you have to join them to widen. Now skull base blade. To flush this posterior table with the skull base.
Yes, sir.
See, this is safest way away from the skull base.
Yes, sir. The cutting edge is in view.
Yes.
Though it is reverse, it becomes straight with 70.
Yes. See under vision.
Yes, sir.
See how the frontal posterior table is flush with the
Skull
ethmoidal
base.
roof. That is ethmoidal roof.
Yes, sir.
It is flushed.
Yes, sir.
Whatever opening you made for a frontal, see the drainage pathway. So big.
Yes, sir.
That is the key.
It is never going to stenosis, sir.
Never. Your irrigation will keep it patent. Your irrigation will keep the inflammation down. And see, I didn't disturb any disease medial to it in the olfactory cleft. Yesterday also you have seen, never ever disturb the disease in the olfactory cleft. It is never going to bring back your olfaction.
So the take-home message is, sir, never touch any polyps just medial to the middle turbinate.
Superiorly.
Superiorly, sir. Yes.
See, that's the part of the middle turbinate I have taken off
Yes, sir.
and widen thoroughly. This is thorough widening. See that? The widening.
Yes.
This pure frontal sinus work.
Complete job, sir.
Adequate frontal sinus work, you can say. Now what I will do, I will remove the bulla and look at the anterethmoidal skull base.
Yes, sir.
we haven't done anterior skull base complete, particularly posteriorly. Only anterior work has been done.
Yes, sir.
This is your maxillary sinus there.
Yes, sir.
That is your orbital floor. And this is your remnant of the bulla.
Yes, sir.
This one. See this thick bone?
Yes, sir.
See this osteitis.
Yes, sir. There is a part of bulla.
This is bulla only.
Yes, sir.
See how osteitic. Thick osteitic bulla.
Yes, sir.
Okay. And now we'll try to reach to the anterior skull base.
Yes.
Sinus surgery is not about doing the sinus surgery. You have to do a comprehensive job at the same time preventing complications.
Yes, sir. So actually, sir, you are repeating the same steps every time. So
Yeah,
it is
same.
leaving a impression in our mind. We have just memorized all the steps and it's a revision class.
Again and again, that is same. The principle remains same.
Yes, sir. That is the beauty of this workshop, sir. We have seen the same steps in, I think, 10 times.
See there. See the anterior skull base? That's the region where the anterior artery is likely to be.
Yes, sir.
With the cell I have completely uncovered.
Yes, sir.
See the skull base.
Yes, sir.
Very clear?
Yes, sir.
See now right with the 70 degrees, right from the frontal sinus.
Yes, sir. You always recommend, sir, while dissecting at the anterior ethmoidal artery, always remain medial or maximum at the midline, not lateral.
Not laterally, never.
Yes, sir. You always recommend, sir.
See this polypoidal mucosa within frontal.
Yes.
Once the irrigation starts going, it is going to, once the aeration is established, drainage is established,
Yes, sir.
when the irrigation starts going, it is going to come back.
Yes, sir.
You don't need to extensively, traumatize that.
Yes, sir.
So that's the anterior skull base work.
Actually, we were late, sir. So, is there any supraorbital sign on the left side?
Not, there is a
We
very
didn't
shallow
see the
recess.
CT. Okay, sir.
Very shallow recess,
Okay, sir.
not significant.
Okay, sir.
See the complete frontal and the anterior work.
Beautiful, sir.
Like we did on the opposite side. Now I will change to 0 degree.
Yes, sir.
And the rest of the posterior ethmoidal and the sphenoidal work. And then we will move on to the JNA. See the difference in visualization on both sides. To the frontal.
Yes, sir.
See here, you can go and see there. And there, once you remove this axilla, this part, everything is in front of you. 0 degree visualization.
Yes, sir.
See now, the post-ethmoidal work. This ground lamella is nothing but the second part of the middle turbinate as it turns, lying in the coronal plane.
Yes, sir. Sir, though you have removed the middle turbinate, the polyp over the septum looks like a middle turbinate.
Pardon?
So the polyp over the septum looks like a middle turbinate.
Yeah, it is swollen up.
Yes, sir. Though I have removed,
Yeah. So never disturb that state.
it's just Xerox copy of the turbinate.
Yeah. So don't get disoriented.
Yes, sir.
हल्का हल्का पानी डाल. Now see, that is my maxillary line.
Yes, sir.
See, entering into the post-ethmoid. Entering into the post-ethmoid.
Yes, sir. Not above the roof of the maxilla. Just
No,
same line.
yes. That's a safety caution.
Yes, sir.
And this is your superior turbinate. See this?
Yes, sir. Yes, sir.
That is the superior turbinate. I have taken a little bit. And see, at this level, this is lower part.
Yes,
At
sir.
this level, this is septum.
Yes,
See,
sir.
medially the septum.
Yes, sir.
This is the turbinate there. This one.
Yes,
That's
sir.
the level of the maxillary line.
Yes, sir.
And here I can see the sphenoid sinus. See that?
Very small opening, sir.
Yes.
Yes.
See this level of the maxillary line.
Yes.
See this.
Yes, sir. We are inside sphenoid.
Idea is this is along the septum. See, this is septum.
Always remain close to septum.
Yeah, this is middle, superior turbinate. It's still lateral to medial to it.
Yes, sir.
And now everything anterior to the ostium has to go. It
It's
is
a
huge ethmoidal chunk.
Yes, sir.
All
You
these things
say-
have to go.
You said, sir, it's a garbage.
Now, see this?
Yes, sir.
See this? These are thick septations because of osteitis.
Due to osteitis, sir.
Yeah, I'm breaking them. These are thick bony partitions.
Yes, sir.
Now, anything coming anterior to the ostium,
Yes,
that's the
sir.
ostium.
Yes, sir. We are safe as long as we are anterior to the sphenoid ostium.
That's the bottom line.
Yes.
Any critical structure behind in the sphenoid cannot come anterior to the
Ostium.
ostium.
Yes, sir.
There's one thing can save you from all complications one can give within the sphenoid sinus. See, I have flushed the skull base thoroughly.
Yes, sir.
See, flush the skull base thoroughly. Remove everything. See, this is a cell.
Yes,
Can you
sir.
see this?
Yes, sir.
This is Heller cell.
Heller cell.
One can miss this easily.
Yes, sir.
What you need to do is communicate this with the sinus.
Maxillary sinus. Yes, sir.
See this. Many a time this cell is, we have seen, even bigger than the sinus itself. One can get disoriented. See the Heller cell?
Yes, sir.
Okay. 40. You have to thoroughly communicate it with the sinus. See this cell?
Yes, sir.
See how important this is.
Yes, sir.
One should never.
Is this cell extension of an ethmoid or post-ethmoid in this patient?
This cell is basically
In this case,
ethmoidal cell pneumatizing the maxillary bone.
anterior group or posterior group? In this case,
Anterior ethmoids pneumatizing the maxillary bone.
yes, yes.
This is all these fancy named cells. Maybe Onodi cell,
Yes.
frontal cell, cone cell means there's Heller cell, any fancy named cell are all ethmoidal cell pneumatizing the surrounding bones.
Yes.
See now how big actually the Heller cell is. Could you see?
Yes, sir.
So always clear this infero-medial orbital angle. That's why I always mention.
Yes, sir.
You'll never leave this cell unaerated. One can easily miss otherwise.
Yes.
See how big the Heller cell is. So that's a nice anatomy. A reasonably good size Heller cell. I have communicated
Yes, sir.
well with the maxillary sinus. See that?
Yes, sir.
That's the answer to this problem. Now the final remaining anti-ethmoidal work. Wash. State debrider. State debrider. Wash today. The final post-ethmoidal work and widening of the sphenoid. So bilateral full house fast is a marathon. See, that is your sphenoid sinus.
Yes, sir.
That is your skull base, just to reorient you.
Yes, sir.
All skull base, skull base.
Yes. Yes, sir.
All these cells anterior to it have to go. That was the Heller cell. And now lastly will be widening of the sphenoid sinus.
So actually, sir, skull base is tapering downwards. It's not in a straight
Sloping.
line. Sloping
Sloping.
downward. Yes, sir.
Yes, always it is sloping.
Yes, sir.
See now?
Yes, sir.
Everything done except the sphenoid widening. Section there. Section. See the maxillary, the halar. That's the coina. That's the sphenoid sinus. That's the postethmoids. Postethmoidal skull base. All done. All done. All done. See all the way.
Yes, sir.
The only thing which is left is the sphenoid sinus widening.
Widening. Yes.
See the sphenoid sinus?
Yes.
Yes. Using your through biting, and now I can use my sphenoid punch. Oh, towel again, huh? See the sphenoid?
Yes, sir.
This small opening is never going to serve the purpose.
Yes, sir.
Debrider.
And we should never widen it inferiorly, sir.
Yeah, that may take away injure the vessel.
Yes, sir.
That may injure the vessel. So always widen laterally towards the anterior wall
Yes,
and
sir.
under vision little bit superiorly, because superiorly it is close to the roof.
Yes, sir.
Remove the party wall between this and the onodi, if there is onodi.
Yes, sir.
See the sphenoid?
Yes, sir.
See the anterior wall. See this anterior wall. I am removing.
Yes, sir.
See the party wall. Between this and the ethmoidal cell.
Yes, sir.
Wide and adequate.
So how much should we widen the sphenoid, sir?
To the safe limits. Find out. Line. See the interior of the sphenoid coming up?
Yes, sir.
See how much the polypoidal mucosa was?
It will revert back, sir.
Still, I will take away this medial bone a little more. See this medial bone.
Yes, sir.
Find out, yaar. मोटा नहीं लेते कभी। Debrider. See, I have reasonably good widening. Let me see.
Yes, sir.
See now?
Yes, sir.
What is that? Find out. So this. Mhm. Now see finally the sphenoid. This is for sphenoid only.
Yes.
We use reverse blade. See this?
Yes.
Because the direction is anteriorly, not behind. You can check the floors if any polypoidal mucosa. See this?
Not advice for beginners, sir.
Yeah, anything blindly in the sphenoid is never advised. But this is a safe move with the reverse blade facing anteriorly to you, and that too in the floor inferior-medially.
Yes,
See
sir.
now the panoramic view.
Yes, sir. After opening 100 sphenoids, one can try.
Yes, you're right, maybe. See the entire skull base.
Yes, sir.
How eosinophilic disease it was bleeding all the time. See this? See the panoramic view?
Yes, sir. Beautiful, sir. All sinuses in single view.
Oh, sorry, I forgot to show you the. Okay.
It's not looking nice.
Septal correction.
Septal correction, not it giving nuisance.
No, let me show you at least. This limited correction. High deviation. This is important, high deviation, because right now what you are seeing is a decongested nose. What I'm concerned is with this high deviation. See this? Not with anything else.
That is of more concern regarding the disease.
Yeah, not with the lower spur.
Yes, upper one.
This high deviation.
Yes.
No infiltration, sir.
No.
Even
I
normal
told you
saline.
Yeah, if you want for hydrodissection, you can
Yes.
infiltrate normal saline, but not needed. See this high deviation. This is the deviation.
Yes, sir.
This is the culprit. Can you see?
Yes, sir.
This small thing can change the life. Only this small thing.
Lies everywhere.
Yes, sir. It requires another 5 minutes only,
Yeah.
but makes
But
life
see-
easy for the patient.
See, this is the culprit, this high deviation.
Yes, sir.
Never pull.
A twist just.
Bite through. And this will bring the septum to the position that it will not impede
Beautiful.
that is the main deviation.
Yes, sir.
Finished. Finish that high deviation. See this?
It took less than 2 minutes, sir.
Yeah. And it is so important.
Yes, sir.
It can ruin the entire surgery, boss.
Yes, sir.
See this? Now no more deviation.
Yes, sir. Aswani sir is insisting, sir, to remove the posterior spur, sir.
Posterior spur is not bothering. Why to unnecessarily?
cosmetic value or they have got cosmetic value.
Who is looking into the nose for cosmesis? Surgeon's itch. That is surgeon's itch only.
Yes, sir. A temptation.
See this? Open down. See now, everything, the high deviation is over.
Beautiful, sir.
It should be done. It should not take long. Here's the final picture. Here's the final picture. Now, when this guy irrigates, everything will reach to the area where we want.
Yes, sir.
Can you see? Your
Beautiful,
olfactory
sir.
area is so accessible now for the topicals. See this?
Excellent, sir.
So this was a bilateral full house fest. We always call it as a marathon. See this?
Yes, sir.
Thank you. Thank you for your attention. And next phase is getting ready. Very soon we'll be there.
Thank you so much, sir.
5 मिनट के लिए एनेस्थेटिस्ट को लिस्ट करवा लो आप भूल गए चलो हम भूल गए एनेस्थेटिस्ट को लिस्ट करवा लो इमेज की तरफ
Anesthetic को? कर.
5 मिनट चाहे
बंद कर.